Okay, so for my reviews, I like to do like a little bit more open form discussion and stuff. I have like kind of some sample questions and kind of get some jumping off points. But any questions before we begin with this material? You guys are experts on the field. We don't even need to do the review. You guys take the test right now, right? Whoa, okay. Yeah, I guess you guys need a little bit of time to start over this. Anywho, let's try out some maintenance fluid calculations. Ooh, these are good ones to be able to do in your head. I know, I'm gonna go right for the jugular right off the bat. So okay, so if we had a 10 kilogram child, remember the rule is 4-2-1. If we had a 10 kilogram child, what would be their maintenance fluid rate? 40 mLs per hour, right? Because you do 4 mLs per kilo for that first 10 kilos. All right, perfect. How about an 18 kilogram child? Think 60? I know it's too early, but hopefully you got your coffee. 56? Okay, well, how'd you get 56? Magic? I don't know. So we do, for the first 10 kilograms, it's 40 mLs an hour, right? And then we do 2 times every ml, or every kilogram for that next 10. So 2 times 8 is 16 plus 40 is 56. So that's your maintenance rate for a child of that size. How about 36 kilograms? You think 76? Okay, right, so for the first 10 kilograms, it's going to be 40. For the next 10 kilograms, it's 20, because it's 2 mLs per kilo for the next 10. And then 1 ml per kilo for every kilo after that, right? So it would be 40 plus 20 plus 16, right? So then that equals 76. So these are really easy to do once you do like several, so you can just make yourself fake patients and just kind of be able to do it in your head. Because we do this all the time in the clinical world, especially if you work with any children. How about a 70 kilogram adult? 110. What does anyone else think? 110. Okay, good. So we have 40 plus 20. Right, so that's our first 20 kilograms, and then we have an extra 50 mLs after that. So 50 plus 60, 110. Perfect. And then finally, 100 kilogram adult. I think 140. All right, so we'll do 80 plus 60, so it'll be that 140, right? Good, because like normal, like if you ask anyone like what normal maintenance fluid rate for an adult, they say like 125 mLs an hour. But you can see how that probably works for most adults. But if you actually did it on the weight-based scale, they might need a little bit more as they get a little bit bigger.
I'm not following at all.
Okay, that's fine. We can go through this again. Yes.
So the first 20 kilograms, you're always going to have 60 mLs per hour.
Exactly. Yeah. So
just add whatever's left over.
Exactly. Okay. Yeah. So for the first, like if you go back to that 18 kilogram child, right? So we know that for the first 10 kilograms of that weight, it's going to be 4 mLs per kilo, right? So if a kid's over 10 kilograms, automatically there's at least 40 mLs an hour is going to be part of that, right? And then so for that next portion of it, the next 10 kilograms, it's going to be 2 mLs per kilo. So that 8 times 2 would be 16, plus that initial 40, then you get your 56, right? So then if you were to go up to the bigger weight kids, once they get past that 20 kilograms initially, you'd have that 40 for the first 10, you have 20 for the next 10, and you're adding 1 ml per kilo for every kilo after that, right? So it's an additional 16 mLs per hour you're going to add on. So you have 60 plus that 16, you have your 76. That make sense? Clear as mud, everyone? So just practice that. Just be able to do it real quick on some scratch paper or something if you can write it out. Just remember that 4-2-1 rule, and that will keep you pretty safe for the majority of patients you'll deal with out there in the clinical world. Can you think of anyone who might need like less maintenance fluid rates, who need a lower rate? So like kidney problems might be one. Anyone else? Anyone who's like fluid overloaded to begin with. So if you imagine someone had like really bad ascites, if they were having pulmonary edema, those would be cases where you might not want to be giving them as much maintenance fluid rates because they will potentially have worsening of that. So just something to keep in mind. But for most of your relatively healthy patients, you can get away with the normal 4-2-1 rule. Okay. So let's imagine we have a patient who has been diagnosed with endocarditis. We have been treating him for some period of time now. So he's a 64-year-old man. He's being treated empirically, right? Because we start off with empiric therapy because we don't have our cultures initially, right? And we always do our cultures first. So we're thinking infective endocarditis. He's been on vancomycin because remember that's a good broad spectrum killer for a lot of our gram positives, right? You know, is there anyone you might think might be more at risk for, say, like gram negatives or things like Pseudomonas? What type of patient? Maybe like an IV drug user would definitely be a good one to think about. Maybe if they're more immunocompromised, they might be more prone to it. But this is a regular old 64-year-old white dude. We're just going to be, you know, we have no suspicions that he's an IV drug abuser. You never know, but we don't have any suspicion. So we're going to go with vancomycin. So he's been on it for the past 3 days. And then clinically, he appears to be improving, right? So he's starting to look a little bit better for us. And then you get your cultures back. Okay, so it says viridin streptococci. And this is the susceptibility report we have. So it says penicillin susceptible, ceftriaxone susceptible, vanco and linezolid all susceptible. So at this point, what would you want to do to that patient's regimen?
Narrow it down.
You want to narrow it down? He wants to like continue with the vanco. Like he's looking better, he's continuing on. Yes?
Oh, never mind, I just answered my question.
Good job. That was pretty efficient. I didn't have to do anything. It's perfect. So who thinks they should just continue on vancomycin? You know, you think so? Okay. Why would you do that?
Because it covers the gram positive stuff.
Good. Okay. So you're still treating the bacteria, right? So that would not be completely inappropriate to take him off of vancomycin, right? Especially if we were concerned there might be other, you know, polymicrobial infections or something. But for the most part, when you get results like this back, you typically want to narrow down your coverage, right? Because we don't want to use a really broad spectrum big gun like vancomycin because then you run the risk of what happening? Resistance popping up, right? So what we can do is actually scale down our therapy. So even though you have a big list of drugs that say, you know, these are all susceptible, you typically want to go with the thing that is going to be most susceptible. So, or the narrow spectrum drug that's susceptible. So in this case, what drug would you go with? I think penicillin, okay. And then if you had like, you know, a really significant penicillin allergy, what would you go with? Yeah, ceftriaxone might be a good option, right? You know, linezolid is really something you wouldn't want to use unless, you know, the stuff came back resistant to vancomycin, right? Or there was some reason you couldn't receive vancomycin, you know, you just couldn't get your levels right, his kidney function was too labile, whatever it happened to be. But yeah, absolutely. So, you know, penicillin would be a really good option here because it's narrow spectrum, and then you could, you know, continue on your treatment. Is there any other drugs you'd want to have potentially on board?
Gentamicin.
Think gentamicin? Why would we do that?
Synergistic effect.
Good, absolutely. How does that synergy work?
Loosens up the cell wall.
Absolutely. So the vancomycin or your cell wall active drug is going to help kind of loosen things up a little bit, as you said, make them a little bit more permeable. Gentamicin can get in there and have its activity. So this is really the only case we're going to be seeing, little Bro 5 back there. This is the only case where you're really going to be seeing gentamicin being used for gram-positive bugs for the most part, is in this case of synergy. So never by itself, really only has gram-negative spectrum of coverage by itself. Good.
Not only for endocarditis.
That's really the only place I've seen it. There might be some other cases, but I just haven't run across it. This is really the go-to one, though. Just because those vegetations are so difficult to penetrate, especially if you have, like, you know, mechanical heart valve and you have this you know, difficult to penetrate kind of vegetation, you know, growing on this foreign material. You need to treat for a long period of time. So this is why, you know, you end up having you know, weeks and weeks of treatment as opposed to, you know, say 14 days. And so using the gentamicin, you get shorter treatment times as well, which is beneficial. Yes. Potentially, it depends on how you're dosing it. And remember what drugs we do therapeutic drug monitoring on. So gentamicin, and typically you're going to see lower doses being used for this situation than you would see if you were using it therapeutically by itself, or, you know, so for something like, you know, a community, or, you know, healthcare acquired pneumonia or something, you would definitely be using bigger doses. But yeah, so that's a perfectly valid concern. So you have a, you know, a little bit older guy, you're concerned about kidney function. You know, vancomycin is also renally eliminated, so you'd also want to be checking levels for that as well to make sure you're getting things in the right range here. If you had to imagine, if you're shooting for, you know, a vancomycin trough, would you want to go for a little bit lower or a little bit higher concentration? Because usually, like we talked about ranges of vancomycin concentrations when you're doing therapeutic drug monitoring, because with vancomycin, not only are we doing it to make sure we're not getting toxic, we also want to make sure that we're staying above that MIC, because you remember the MIC is, if we get below that, what's going to happen? The bacteria is going to keep growing. It's not going to be good for us. We want to keep it above the MIC, and so usually you're also checking for efficacy at that point as well. So for certain indications, you can get away with lower concentrations, like say 10 to 15 mics per ml, versus if you were going with some other indications, you want to shoot for higher, say 15 to 20. So like meningitis, you want to go for higher concentrations because it's more difficult to get to the CNS. For pneumonia, it's more difficult to penetrate the lungs, so you go for higher concentrations. What do you think about this one? Do you want to go higher or lower? Think lower? So you would think lower because, especially for bacteremias, like if you're infusing the drug straight into the bloodstream, like you have pretty good concentrations there. And you're right for the most part. If you're dealing with like just a regular bacteremia, that is absolutely true. But because we have this vegetation here that's difficult to penetrate, we actually want higher concentration. So this would definitely be like a 15 to 20 kind of situation. Not that I would ask you, to select the therapeutic range on a test, but just for your reference, that's kind of the thought process that goes behind these things.
Rifampin is only for mechanical heart valve issues?
If you have certain resistance patterns, you may add rifampin on as another agent, but usually the mechanical ones are more difficult to treat anyway. So yeah, definitely you'd use rifampin then. And when do you add rifampin on?
Last.
Right. Why do we do last?
Because of resistance.
Yeah, so it develops resistance pretty rapidly, so you add it on last, so that way, hopefully, your other, if you're using something like, penicillin plus gentamicin, those have kind of started to, work on the bacteria, kind of help make them a little less likely to develop that resistance. So by adding the rifampin on last, hopefully you can curtail some of that. Cool. Any other questions on that? All right. So looking at our antilipemics, what do you think would be the most appropriate treatment for the following patients? So the first one we'll look at, we have a 27-year-old pregnant female. She has an LDL of 165 milligrams per deciliter. What do you think would be good for her? You want to do a resin? Okay, it's like a bile acid sequestrant. What would be some options in that category? Starts with a C. Right, so we have like cholesterol, cholecalciferol, kind of falls in that category. Why would you use that for this category? Why would we use it for a pregnant patient? Good, so it doesn't get absorbed, right? Because it's working directly in the GI tract to bind up those bile, the cholesterol and whatnot, and prevent it from being absorbed. So this is going to be usually preferred for pregnant patients if you needed to treat their high cholesterol, right? That's a good option. What would be contraindicated? Yeah, statins, absolutely. You would not want to use statins for a pregnant patient because we know there's really big fetal risk for that. So we never would want to do that. So definitely a category. What kind of category would it be pregnancy-wise? D or X? X, right? So X would be something that there's really no therapeutic benefit to using it for. D is something that there may be a risk-benefit analysis or situation that you could run where you would want to go ahead and treat that patient. So something like lithium, something like warfarin potentially would be category D. Okay, so then we have a 68-year-old male with type 2 diabetes. He has a previous history of heart attack. What's going to be the best drug for him?
First one, what did you say was the best one for that one?
So the bile acid sequestrants? Yeah. Okay, so this next guy, he is pretty typical patient. You're probably going to see a lot of guys like this in your clinical practice. What is going to be the best therapy for him? Remember, going back to those newer guidelines we had out there. So is he at risk for having further cardiovascular problems? Absolutely, right, because he's got diabetes, he's had previous heart attack, he's probably, has some ventricular remodeling happening. All kinds of bad things are kind of setting him up for future problems. And so what would be the best drug in order to help prevent future cardiovascular risk? Are statins. You guys remember the newer guidelines? They're not really shooting for specific numbers as far as getting your LDL this low, getting your HDL this high. They're really looking at cardiovascular risk, and it's not just due to the fact that statins lower cholesterol. It's all these other pleiotropic effects they have, right? They help to stabilize those plaques. They help to prevent a lot of inflammation and prevent platelet aggregation. All these other things that don't really go back to its mechanism specifically, but have beneficial effects on reducing mortality and future cardiac events for these patients. So So statin would be a very good option for this patient because he is such a high-risk patient. And if you were to look at it, do you think he would go kind of high intensity, medium intensity statin therapy? What do you think you'd go for? Probably pretty high intensity, right? Because he is such a high-risk patient. Even the diabetes itself kind of puts him in a higher category already to do high intensity. So when you are titrating your dose of statins, what's kind of your rate limiting factor on that? What's kind of limiting how high you can drive up your dose? Absolutely. So side effects are really going to be the biggest thing. So you'll have recommendations as far as like the dose you can administer. You can really only go up so high as far as your patient can tolerate it, right? So if he happens to be really prone to having myopathies or having other side effects, like if you had some hepatic issues or something like that, that would kind of limit how high you can drive that dose. But basically as high as the patient can tolerate.
So the myopathy, it doesn't become a cardiomyopathy?
Not really. It's mostly you see this kind of like peripheral muscle breakdown that's occurring. Yeah. Good question, though. How about we had an 18-year-old male who has familial hypertriglyceridemia, has a triglyceride level, comes back at 350 milligrams per deciliter.
Fibrate?
Think a fibrate would be a good option? Okay. Anything else we could use? Yeah, so remember the two drugs classes that are really working, have big effects on your triglycerides. You're going to be like your niacin and then your fibrates, absolutely. So fenofibrate, gemfibrozil, and then your niacin products. What's kind of one of the big side effects with niacin you'd want to let your patient know about? Yeah, flushing can be a big thing. So make sure that if they're more prone to it, obviously using extended release products limits that, but taking aspirin beforehand can help because it helps to limit that prostaglandin synthesis, which is good. Good. And then let's say we have a 25-year-old female with no past medical history and an LDL of 89 milligrams per deciliter. What would you use for her? Anyone? You don't always have to use drugs, guys. Like you can just tell her she's fine. She's good to go. Yeah, so remember if you go back and look at those risk categories, like she doesn't have diabetes, she doesn't have high LDL to begin with, she doesn't have any risk factors for cardiovascular death that we know of based on this information. Don't have to do anything, right? So just think about that. Sometimes the best drug is no drug. Unless I have, some stocks in the company and then all the drugs. Just kidding. Okay, so let's say you had a patient who came in, 46-year-old male, chief complaint. He says, my legs, I feel like I've been running a marathon. He's a pretty sedentary guy. You can tell he's never run a marathon in his life. Past medical history, he's got hypertension, he's got hyperlipidemia, angina, obesity. And if you look at his medications, we can kind of see what he's been on for the previous period. So he's on atorvastatin, 10 milligrams every night. He's been on that for 2 years, so he's been on that for quite some time. He's on fenofibrate, 130 milligrams once daily, which this was started last week, for still having continually high cholesterol. Verapamil for his angina, 120 milligrams 3 times a day. He's been on it for 6 months. So what do you think is happening with this patient?
Statins and fibrates.
You think the statin and the fibrates are the culprit here? Okay, so initially, what's your big concern when you have a guy that comes in saying this? Yeah, so you worry about the muscle breakdown, right, which can lead to what? Yeah, rhabdomyolysis, right? So especially if he came in saying like, yeah, my pee this morning and it looked like tea. Like that's a really bad sign, right? That shows there's a lot of myoglobin in the urine. That's where you want to get him lots and lots of fluids to make sure you don't have that precipitate out, because really the kidney injury can be one of the big things you worry about that as well. So you mentioned the atorvastatin and the fenofibrate being the big issue here. So what is that interaction? Like synergy. So this is a good one. So fibrates will decrease the metabolism of your statins, and so that's one of the big interactions you want to be aware of. Is that so he's had this fenofibrate on board, which is probably driving up his levels of atorvastatin. Do you guys notice any other interactions that are happening here as well? Any other, like maybe like a CYP3A4 inhibitor you might be on? Perhaps the only other drug he's on. Right, so verapamil could be the other thing as well. So if you think about it, like you can adjust your dose of your statin to a point where they don't necessarily have to stop therapy. And so this was probably a case where he's on a pretty puny dose of atorvastatin. So they've probably adjusted it at some point to where he could be on the verapamil and the atorvastatin at the same time, and that's okay, right? His levels are not being driven up so high. He's having these problems. But when you add it on the fenofibrate, all of a sudden you kind of tip the scales a little bit, and now his levels are way too high, and he's experiencing this muscle breakdown, these myopathies. myopathies. So just keep that in mind, that even though a patient has had a previous drug interaction, you can have new things come on board that can kind of throw things kind of out of whack to some degree. So in this case, what would you do for this patient? You say, yeah, you'll be fine, just go walk it off.
No.
No. Is there any drugs you'd want to stop or change the dose of, or what would you do?
I might pull back the fibrate for till
So,
it's better.
yeah, so there's lots of options here. So I would probably, at the very least, probably stop the atorvastatin until the myopathies is kind of resolved, right? Probably the fenofibrate too at the same time, because obviously, if you're thinking about what's going to be immediately harmful to this patient, it's probably not his cholesterol, right? He's probably not going to drop dead of a heart attack because we stopped his atorvastatin for a couple of days. But certainly, you'd want to discontinue therapy for right now, and then you can kind of readdress it once he's kind of back at his baseline. Any labs you'd want to get on him, just out of curiosity?
Urinalysis.
Probably urinalysis might be a good one. Anything else?
Kidney function?
Yeah, absolutely. You want to look at kidney function. You can also look at a creatinine kinase as well. So a CK level would be really indicative of how extensive the muscle breakdown is. So it tells you, whether or not he's really like a kind of full-blown rhabdo or not. So, and then typically, like, you're just going to pump him tons of fluids to try to make sure that myoglobin doesn't precipitate out in the kidneys. But anywho, so that might be a common complaint that might come in, or maybe not common, but a complaint you might hear that you can look at the drug history and know that, okay, yeah, this is obviously a problem here. So, any questions on that?
He doesn't need to be admitted. He just needs to be told.
Depends. I don't know. It depends on how significant it is, and especially, 46-year-old guy is probably pretty healthy for the most part, but you never know. It could be,
All these meds on board, so.
well, got some heart disease. Who knows? So again, it all kind of depends on your clinical gestalt and what the labs are coming back as. If his creatinine has doubled all of a sudden, like, that's probably a bad sign. You need to probably get him tanked up with fluids and send him in. Probably more likely to be, yeah, it would really depend on what the labs come back and kind of how long it's been going on for and things like that. So it'd be hard to say right off just this information.
Do fibrates decrease the level of statins or increase?
It would increase them.
Okay.
Yep. They decrease the metabolism of the statins, so it would increase your level.
Increase the level.
Yep.
Okay.
Mm-hmm. Yes.
So if he starts to get better, do you just put him on different meds instead of?
So you could consider, if he was fine on the verapamil and the atorvastatin at the same time, you could start back at the same dose and then maybe pick a different drug. So maybe like, maybe you could do like a reduced dose of like a niacin type product or something like that. Or maybe even just by titrating his dose up on the atorvastatin, maybe he would have better results on his cholesterol, right? So it just depends on your patient.
Sorry, what reaction did you say verapamil and atorvastatin have?
I'm sorry?
What reaction did you say verapamil and?
So that's a CYP3A4 interaction there. So verapamil is a CYP3A4 inhibitor. So it's important to remember those interactions. So that andotizin will do that as well, right? So it's a big interaction you got to worry about. Any other questions on this one? All right. You guys didn't like the title for that last one? Legs are statin to hurt. Yeah. Anyway, I probably spent like half the time making this slide set just on that title. Okay, so next, looking at electrolyte shifts. This is really, really important with some of your cardiac patients. So which medications can cause the following electrolyte shifts? So say you had a patient who had hyperkalemia. What drugs could have caused this that we've talked about for this unit? Potassium-sparing diuretic. Okay, good. What would be a good example of that? Spironolactone. Absolutely. So that's an aldosterone antagonist. So spironolactone could do it. Specifically, the potassium-sparing diuretics, so tramturine and amiloride will be in that category. Good. So those can all cause hyperkalemia. What else can do it? Anything that inhibits like aldosterone from being secreted more. ARBs, so your angiotensin receptor blockers could do that, certainly by inhibiting that renin-angiotensin aldosterone system. You can help drive potassium levels up. And so if ARBs can do it, what else can do it?
ACE inhibitors?
Absolutely. So ACE inhibitors can do this as well. Perfect. So be aware of those potassium shifts. That can be potentially very dangerous for patients, especially if they're on antiarrhythmics like digoxin and things like that. So be aware of those shifts, especially if they already have kind of pre-existing kidney disease. They may not be able to filter potassium appropriately anyway, or if they're on potassium supplements because they're on other diuretics. So be aware of those changes, that when you add on a new medication or you change dose, you can see those shifts occur. Okay. How about things that cause hypokalemia? Loop diuretics, absolutely. What else can do it? Any other diuretics? Thiazides will do it too, absolutely. So thiazides will cause your potassium to go down. Loop diuretics will cause your potassium to go down too. And you end up seeing some patients will be put on supplemental potassium in order to help kind of counteract that in the long term. So be aware those can cause hypokalemia. How about hypercalcemia? What can cause that? I think I heard it. Thiazide, yeah, absolutely. So remember, thiazides can sometimes be used in order to help prevent production of kidney stones, it's calcium oxalate crystals, because they actually help to increase reabsorption of calcium. And so you can see hypercalcemia actually develop from thiazide use. That's kind of one of the big differences between that and your loop diuretics, is that loops will cause calcium to be excreted, whereas thiazides will cause more reabsorption of that. Good. What kind of patients could you not use a thiazide diuretic in? People with already high calcium? Yes, that is very true. How about patients where the drugs won't really be effective? Yeah, absolutely. So decreased kidney function. Usually if you have a creatinine clearance less than 30, your thiazides aren't really going to be that useful, right? So what could I use instead? A loop diuretic will still be effective, right? And then there's one thiazide that actually will work. The M1, yes, the M1. It's metolazone, so that one will still work even in kidney dysfunction, so that's good to remember. So then hypomagnesemia, what could cause that? Yep, loops can do it. And thiazides, yeah, absolutely. So, so most of your diuretics will be able to cause hypomagnesemia as well, which again can be a problem, for some of your cardiac patients as well. Probably not as big of a deal as potassium, but certainly magnesium is definitely needed in the body. So, does that make sense as far as how the shifts are occurring here? So in some cases, you may have a patient who, say, is on a thiazide chronically. You could actually put them on to like an ACE inhibitor, and you'd actually have kind of a balancing out of those potassium effects. So it's important to remember, looking at your patient, do they already have a potassium of 5.3 with kidney issues? Maybe I shouldn't put them on this ACE inhibitor, right? Because I could drive that up even higher. So think about things like that before you prescribe. Okay, what drugs would cause the following in overdose? I like overdoses quite a bit. I spent a long time training with them. So if you saw a patient who had hypotension and bradycardia, which antihypertensive do you think could cause that picture? So you said an alpha blocker. So why wouldn't an alpha blocker cause that particular picture? Right, the bradycardia, right? So with an alpha blocker, what you should see, because you're decreasing that total peripheral resistance in the vasculature, what's the heart going to want to do? Right, it's going to want to compensate by increasing cardiac output, increasing heart rate, all that stuff. So what you typically see with like an alpha blocker, you'd actually see hypotension with tachycardia, right? So that was what you'd see with that. But what could cause bradycardia hypotension? Beta blockers potentially. Yep, absolutely. What else? Any calcium channel blockers that could do this? Which ones? No. So we got two categories. So you have your non-dihydropyridines or your dihydropyridines. Which ones do you think would be more likely to cause hypotension and bradycardia? Your non-dihydropyridines, so your diltiazem, verapamil, right? And that makes sense because they work on the heart to decrease heart rate, contractility, but they also are going to work on the vasculature as well to decrease the blood pressure, right? So you could definitely see that. Beta blockers, calcium channel blockers. Any other drugs you could see doing that? How about things that are decreasing your sympathetic nervous system output? An alpha-2 agonist. So clonidine would be another good one as well. So it works centrally by decreasing that sympathetic nervous system output to decrease both heart rate and blood pressure, right? So that would certainly be something you see there. And then hypotension, tachycardia, we mentioned that alpha blockers could certainly do that. Any other drugs? So what would say a dihydropyridine calcium channel blocker do? Would vasodilate. Does that really have any effects on the heart? Not really, right? So this would be another case where you'd end up seeing hypotension and then tachycardia along with that, just due to that heart trying to compensate for that effect. So like I mentioned, when I had a patient who had overdosed on minoxidil, because they're an alcoholic and they want to get the alcohol content out of there, they came in extremely hypotensive, very, very tachycardic, because the heart is just sitting there just trying to catch up as much as it can, but it just can't because you're having just such profound vasodilation that can occur. And so that's really important if you're working, say, like in emergency medicine, or if you're ever dealing with a tox patient. You know, oftentimes you don't know what they actually overdosed on, because either their mental status is not to the point where they can actually tell you, or they're lying to you. And so looking at the vital signs, you can get a lot of clues on what they potentially could have been exposed to, which can kind of inform you on what kind of drugs you want to use to try to reverse that, right? So if I see a patient who's hypotensive bradycardic, I don't really think necessarily an amlodipine ingestion or something like an alpha blocker. I'm thinking more beta blocker, non-dihydropyridine, things like that. So these kind of clues can kind of key you in on what the patient might have been exposed to. So we'll talk more about that later on in the next class. How about tachycardia, hypertension? Anything can cause that, we saw?
Beta agonist.
Think a beta agonist? What kind of beta agonist? Probably not. So actually, this would be kind of a trick question, which I would not ask you on the test. But if you had sudden withdrawal of certain drugs like clonidine, sudden withdrawal of clonidine can cause rebound hypertension, tachycardia. You see with certain beta blockers and things, you can have rebound effects like that. So keep that in mind as well. Sometimes patients will be coming in with vital signs that don't make sense, and then you get better history and say like, oh yeah, well I ran out of my clonidine, stopped taking it for whatever reason, and now they're coming in like this. So that'll key you in on what's going on there.
A beta agonist won't do this? Is it because it'll only affect the tachycardia and not the...
So a beta agonist, so say you have like a beta 2 agonist like albuterol. Typically what that does is it will cause some beta effects on the heart, so that will actually increase heart rate. But when they activate the beta 2 receptors on the vasculature, it actually causes vasodilation. So you end up seeing some hypotension with that. So you'd have tachycardia, hypotension kind of in that situation. There's actually there's albuterol, which has a fairly short half-life and usually just used by the inhaled route, so you don't see that big of a systemic effect necessarily with the hypotension. But there's actually there's another drug called clenbuterol. Has anyone heard of this drug? Actually abused by some like bodybuilders and things like that, because it actually activates beta 3 receptors and cause like lipolysis. So they'll use it when they're trying to strip body fat. But there was a case where case report where actually these two bodybuilders were taking this clenbuterol, which you can actually make in your house. There's instructions online. I would not advise doing. Most of the bodybuilders I know probably aren't great chemists, but not to say they couldn't be. But anyway, these guys took this clenbuterol and ended up coming in very, very tachycardic, very, very hypotensive due to those beta 2 effects on the vasculature. So it's kind of an interesting case where you can see that. Okay, so let's say you were trying to treat a patient with hypertension, but let's say with some various comorbid disease states. Let's see if there's any drugs that are maybe better or worse for them. So let's say you had an asthmatic patient. Which drugs would you maybe want to avoid? That's a good point. A non-specific beta blocker, right? So what would be an example of a non-specific beta blocker? Timolol could be one. Propranolol would be another one. Yeah, all your Enthusi drugs, right, for the most part. Right, so those would be ones you want to avoid. You could certainly try a cardioselective beta blocker, something like a atenolol, metoprolol, right? So certainly cardioselective drugs may be used in those patients with caution. Just let them know that, hey, if you notice your asthma medications are not working as well, let us know. We can switch you up. But yeah, certainly that would be less risky to use a cardioselective beta blocker. Sure. How about a patient with a history of paroxysmal supraventricular tachycardias? So they're more at risk for developing SVT in the future. So what type of drug do you think you'd want to use to treat hypertension? So would you want one that only works on the vasculature, one that works on the heart? So you could certainly try a cardioselective beta blocker, absolutely, because that will deal with preventing excessive sympathetic nervous system activation, causing another bout of SVT. That would certainly be a good option. What else could we use? Non-selective beta blockers could be used in the same sense at that point. What else works really well in the heart? Any type of calcium channel blockers that work preferentially on the heart? So your non-dihydropyridines would be good here as well. So you know, verapamil, diltiazem, these are good drugs in order to help prevent, because they suppress the SA node, the AV node, they can help prevent further reactivation of that SVT. So again, think about their comorbid disease states and think about things that can help prevent, either prevent or kind of harm them in regards to side effects and the mechanisms and whatnot. Good. Let's say I had a patient who had type 2 diabetes. Any type of drugs that maybe you want to avoid or would want to use preferentially? Is there anything that's like really like protective for them that they could be on? So what happens to a diabetic's kidneys over time? They had that remodeling that happens, that nephropathy that can occur. And so this is why you can use kidney protective drugs, something like an ACE inhibitor or an ARB or something like that, that will actually help to prevent some of that kidney remodeling from occurring. So that's actually kidney protective for those patients and will be good for them for a good long time because it can help to kind of stave off kind of further kidney injury that may occur. How about if I had a diabetic patient who's hypoglycemic? Is there any drugs that would kind of mask those signs of hypoglycemia? There is. So think about it. If you're hypoglycemic, what kind of are you more activating your sympathetic or your parasympathetic nervous system? More sympathetic, right? Because you're kind of more of in a kind of fight or flight kind of response. You're getting kind of shaky. You're sweating some. What drugs would be able to mask that?
Beta blocker?
Absolutely. So beta blockers can sometimes mask the symptoms of hypoglycemia. So you may have hypoglycemia, not really realize it, and get those warning signs that say, hey, you should probably go eat something, which can be a could be problematic for patients who are on insulin. You know, type 1 diabetics potentially could be more prone to this. But anyone could have their symptoms masked, right? So again, think about these disease state interactions that can occur here. How about a patient with chronic renal failure? Any drugs that would be good here? Yeah, probably ACE inhibitors, ARBs would be good here. What's the thing you need to remember before you start a patient who has kidney injury on an ACE inhibitor?
What do we have to check?
Not what do you have to check, but what do you need to remember before you start? So I have a patient who has really bad kidney function. Their creatinine clearance is 25. What do I need to remember before starting them on an ACE inhibitor? As far as like dosing goes, or how I'm going to administer the drug. So you remember you want to start low and go slow with those patients, right? Because remember that efferent and the afferent arterioles, Ang2 is really, really important for causing that vasoconstriction on that efferent arteriole that causes that back pressure that allows the kidneys to filter, right? So if I were to take away that Ang2 effect and that efferent arteriole vasodilates, now all of a sudden I lose that pressure, right? It's kind of like letting a kink out of a hose. All of a sudden, it's not going to be having much pressure to actually filter at the glomerulus, and so you can actually cause an acute decrease in kidney function, right? So with those patients, even though the drugs are kidney protective, in the long run, you do need to start low and kind of let the patient kind of equilibrate to that over time. Okay, so they're not absolutely contraindicated. You just need to be careful when you're starting out your drugs. Does that make sense? All right. How about a patient with a history of heart block? Any drugs you'd want to avoid? Yep, so really anti-beta blockers could potentially worsen that, so it might be an option to avoid. Anything else? Yeah, so which ones specifically? Yeah, your non-dihydropyridines probably be ones to avoid here as well. So using more peripherally acting agents might be a good option. Clonidine might be not a good one to use here either, just because it can have some depression on the cardiac effect. So something to think about there. And then how about a patient taking simvastatin? Anything you'd want to avoid? You kind of mentioned it already. Any big CYP interactions? Huh? Yeah, CYP3A4. What antihypertensives can inhibit CYP3A4? Yeah, verapamil and diltiazem are going to be the two big ones there, right? So the big CYP interactions there, you want to avoid that one.
I'm sorry, what did you say?
So verapamil and diltiazem, since they are both CYP3A4 inhibitors, they would cause simvastatin levels to go up, and you can run into that situation we had just a slide or two ago.
Are those the two non-DHP?
Mm-hmm. Yep. So verapamil and diltiazem are non-dihydropyridine calcium channel blockers. Perfect. Okay, let's say we have a patient who has symptoms of bronchitis for 3 days. What do you think would be the best drugs for them? Tessalon pearls? What if you're worried about infection, though? What are you going to use to eradicate the infection? No pit. Why not? Why no therapy? Exactly, yeah. So this is way too early to really start therapy at this point, right? So sometimes the best drugs are no drugs at all. So this is one of those cases where you typically want to have longer period of having symptoms before you really start to think it's more bacterial, because so many of these are going to be viral in nature. So this would not be a patient you necessarily want to throw a Z-Pak at and say, go along the way. This may be a patient where you give them a prescription and say, hey, don't fill this until you've had symptoms for, say, 5 days, or how many ever days you want to say, at which point they can go fill it. And that kind of keeps them from having to make a second visit to you, right? So that certainly is a good option. Some patients will just go fill it anyway and just take it just to be safe, but you do the best you can. If you really did have a strong suspicion of bacterial bronchitis, what do you think drugs would be good for this? What kind of bugs are you worried about? Maybe some strep. Anything else? So with your upper respiratory tract, you also want to start thinking, with these bronchitis, you want to think of atypical bugs as well, right? So community-acquired pneumonia, bronchitis, like atypicals can be a thing. So mycoplasma pneumonia, Moraxella catarrhalis, and all those things like that can be issues here. So what drugs would you want to start out with empirically? Macrolide would be an option, absolutely. Anything else we could use? So doxy would be another good option as well. So that's going to have good atypical coverage too. So obviously you got to remember your contraindications. So if the patient was, say, 6, you wouldn't want to necessarily use doxycycline if they're pregnant. Azithromycin has CYP enzyme interactions, things like that. So take those in consideration. But either of those two could be potential first options.
Would levofloxacin be for the HAP and CAP?
You could use that for HAP and CAP, and you could also, if you had a community-acquired pneumonia or just thinking atypicals, you can get away with something like azithromycin or doxy. The levofloxacin is going to be more for if you're worried about like resistant strep pneumo, or say they've been on previous courses of antibiotics and you're worried about more resistant bugs. That's where levofloxacin can be a good option. Vancomycin is kind of a red herring here because it really wouldn't use that for bronchitis for the most part. That makes sense? All right. So let's look at different drugs we can utilize to treat different kind of pulmonary infections. So let's match the drug to the side effects. So if you were worried about seizures and renal failure, which drug could potentially cause that? The beta-lactam drug. It's a carbapenem. Which one? Imipenem, yep, you're head right. So imipenem would be the one that causes seizures and renal dysfunctions. That's one you don't really want to worry about. Like I said, I really see a lot more Marum in the places that I've practiced, but it's not to say you wouldn't see it elsewhere, depending on the formulary. How about tendinitis? Yeah, fluoroquinolones would be the big one there, good. If you have decreased red-green discrimination, you're just running red lights like crazy, what drug could cause that? It's used for TB. So it's a new drug we haven't talked about previously. Not rifampin. The thiambutol can cause that. So thiambutol can cause some visual acuity decreases. You can see that red-green discoloration happening there. So again, those are good patient education points to let your patients know, hey, you need to come in and get checked out for this. How about B6 deficiencies and neuropathies? Another TB drug. It's going to be isoniazid, can be big with that one. So isoniazid, INH is sometimes how it is abbreviated. So if you ever see INH, that's probably what they're referring to. So certainly you can see that there. How about red discoloration of the urine or feces? Yeah, rifampin is a good one. Good to know there. Anytime you have anything that will change the color of someone's pee or poop, let them know because it might freak them out. I only say that so much because I got really freaked out as a kid one time when my pee turned orange and I had no idea what was going on. I don't know what drug I was on at the time, but it was very, very, very disconcerting. like running to my grandma's house screaming like, "What's wrong with me?" I turned out to be fine though, relatively speaking. So ototoxicity, nephrotoxicity, what could cause that?
Aminoglycosides.
Good, aminoglycosides, what else? Polymyxins, certainly. Anything else? You see like tinnitus and things with aspirin, but what other antibiotic? No, we do therapeutic drug monitoring on it. Right, so aminoglycosides, what else? For the V?
Vanco?
Vanco, yeah, Vanco's the other one. You worry about ototoxicity and potential nephrotoxicity. Good. How things that cause QT prolongation? Fluoroquinolones and macrolides can do that as well, right? Good. What can inhibit CYP3A4? True, but for things like antibiotics.
Verapamil?
Verapamil can do it, yes, but if we're talking about pulmonology drugs, yeah. So your macrolides are going to be the big ones here, big offenders. And how about CYP3A4 induction? This will actually lead to decreased levels of a lot of your drugs. What could do that? Causes red discoloration. Rifampin, yeah, absolutely. Rifampin is really notorious for causing the CYP3A4 induction, so be aware of that. It can drive down levels of a lot of other drugs. So again, check your interactions beforehand. Okay.
Can you figure out what levels they will increase or decrease drugs?
Not really. It's one of those things where like you may have certain recommendations. So say for instance, like you were going to start, there's some patients that you could do like a fibrate and a statin in, right? So you can do things like drop the dose by half, and that can potentially be safe for your patients, guys. So there are some recommendations like that for some drug and some interactions, but you can't really quantify how much is going to be inhibited. Probably depends a lot on the patient. I apologize for that. Depends on the patient and the just how prone they are to having that interaction. So, it's a bad answer to say for that, but anyway. So how would you monitor the anticoagulant effects of the following drugs? Let's say we have warfarin. How are you going to monitor that? PT-INR, perfect. And what kind of range are you looking for say a patient is like AFib, prevention of stroke? 2 to 3, absolutely, 2 to 3. If they have a mechanical valve, you might go higher, say 2.5 to 3.5, but 2 to 3 is a good safe number to go with. How about heparin? How do you monitor that? APTT, perfect. Fondaparinux, or Rixtra. So we know that one is more specific for inhibiting which clotting factor? 2 or 10? 10, right? Because it's very short, so it really can only work with antithrombin 3 on that factor 10. And so which level can we measure to measure the anticoagulant effect? Anti-10A level, yeah. So anti-factor 10A level can be used for that. Perfect. How about argatroban? What type of drug is that? So that one's another direct thrombin inhibitor, right? So it's working specifically on factor 2. So that's a good drug. Say if you have heparin-induced thrombocytopenia that starts for someone who's on heparin, you bridge them over to warfarin potentially with a direct thrombin inhibitor. So knowing that it affects more factor 2, what could you monitor with? Anti-factor 2? No such level that I'm aware of. Huh? You do your APTT. Yeah, so that would still be APTT. Things are mainly affecting factor 2, heparin, these direct thrombin inhibitors. You can get away with doing APTTs for those guys. How about enoxaparin? So that's a low molecular weight heparin. So does it affect factor 10 more or 2 more? Yeah, it definitely does 2 more. It still does some 2, but it affects 10 more. Absolutely. Fondaparinux is just really, really short, so it only does 10. But so given that, what would I measure with? That would actually still be the anti-factor 10A, just because of the fact that it's much more preferential for the factor 10. So yeah. And how about aspirin? That's kind of another trick question. There's really no good monitoring for aspirin. You can do levels of salicylates, absolutely. So that's a common thing. If you have like a known ingestion coming in, you can frequently get aspirin levels to see, if their levels are too high, if they're taking too much, or whatever happens to be.
But you wouldn't run it for like someone who's taking like
Right, so if someone's taking like a baby aspirin every day, like you're not really going to be monitoring for effects, right? So certainly, if say they are more prone to bleeding or bruising, and they're starting to notice things are popping up that are kind of abnormal for them, like then that could be a case where you want to at least check a CBC, check hemoglobin hematocrit, and make sure that nothing weird's going on there. But there's no specific assay you're running to check for the antiplatelet effect you're getting from aspirin.
You can run bleeding time.
Yep, sure you can. Yeah, you do like a thrombin time and things like that, but
bleeding time, like actually cut the patient.
oh sure, if you don't like your patient.
No, really.
Yeah.
Is that what you do if they overdose on aspirin? If they take a whole bottle?
We do salicylate levels at that point, yeah. Yeah, you don't really see a whole lot of like actual bleeding that occurs with patients who have like an acute overdose of aspirin like that, but so you do salicylate levels and run that. So, but yeah, no routine monitoring for aspirin, for at least from the antiplatelet effects. Okay, so what other questions do you have? Glad I'm recording.
In one of your slides, you
Yes.
said that thiazide cause or can forward the uric acid retention
Yep.
from gout.
Yeah.
Yes.
But in the slide, you said it excretes acutely. What did you mean by that?
So chronically, you do see kind of accumulation of more uric acid levels. It's not like it necessarily will. Probably more due to like just an acute volume loss than anything else, but chronically you're more worried about the increase in uric acid levels. So clinically, it's probably not something you're ever going to really come across. But yeah, so like loop diuretics, thiazides, they can all worsen gout.
Initially, you're saying in the
And just chronically, because you can end up having higher uric acid levels at baseline, which can more predispose you to having that precipitation of it in the big toe or wherever it happens to be.
That was my question.
Okay, perfect. See, 2 for 1. Anything else? Okay, I won't be here tomorrow, but I'll be here for another couple hours or so. So if you guys want to stop by and have questions or anything, please feel free to do so. I will try to answer emails through the weekend. Have some family in town, so give me a little extra time to respond to that. But otherwise, I'll see you guys on Monday. Thank you.